TBI, so now we're sort of kind of breaking into that category. And you know someone that has severe TBI, so now what do you do sort of thing? Right, so you could do this, but we're training you better than to do that. You could just pick out of a hat, right? Eeny, meeny, miny, mo. But then again, like you are smart enough to sort of figure out what you want to do, and it's amazing. There's a tremendous amount of keep calm posters. Here's a couple of them. You want to keep calm, obviously, but you don't want to forget how to actually do things. And then, of course, treat the patient. So this is what it all comes down to, right? We started talking about you have a closed, fixed space, and all the things that you want to look for are your cerebral perfusion pressure, and that is the summation of your MAP and your ICP, right? The MAP you can fix, the ICP you're going to attempt to fix, right? There are certain things that you can play with in those numbers. So what are some of your options, right? There's a whole bunch of options, right? This is the person you've already dealt with your ABCs. You've already addressed a lot of the other issues. Now we're just talking about the head, right? For the sake of time and for the lecture, we're just going to deal with how to manage the ICP. So you can hyperventilate. There is some evidence that says in a short period of time, you can actually hyperventilate patients. You bring them down to a CO2 of about 20, 25, right? So you bring them down, but it's a transient intervention, right? This is the thing that you can do quickly while someone is getting your next intervention, while you're doing the next thing, essentially. This is not meant to be a long-term management option, but it is a transient option that you can use, right? So you're just bagging, you're not bagging them to like 40, but you're bagging them at a rate of about 20, 25 to bring their CO2 down as well, right? And that CO2 comes down to about 20, 25, so it's a good number to sort of remember. Obviously, you're not going to keep checking a blood gas, because that is also time that's used that should be time used somewhere else. But you're looking, again, to hyperventilate someone to see if you can follow these things. As a side note, I didn't put it in this lecture, if you're not sure what the ICP is, this is a lot clinical, right? We talked about what is your GCS, what is your pupil exam, what are all these different things. If you're still not really sure, there's no obvious signs of injury, but you have someone who's not really participating in your exam, you can throw an ultrasound on their eyes, and we've talked about that in previous lectures, so that's why I didn't put it in here, because we've addressed that in multiple other places. If you're not sure how to do it, you can always find any of the ultrasound faculty. We're happy to teach you how to do it. It's really simple and easy. It's really quick. You just literally put the probe on the eye, and you look for the optic nerve sheath's shadow, and then you're measuring back there. It's a quick and dirty way to see what the ICP potentially could be. So hyperventilate, fluids, right? So remember, the MAP needs to also be adjusted here. You have to have an adequate MAP in order to adjust your cerebral perfusion pressure. Right? If your MAP is too low, that also causes lung problems. If your MAP is really high for some other reason, that can also be a problem. Things that you also have to consider. Osmotic fluids, which we're going to actually talk about. Sedation and paralysis. These are the first things that we have at our hands, right? So as you've intubated someone, you've paralyzed them to do your intubation, you want to, ideally you want to keep them that way, because the less they're able to buck against the vent, the less they're reacting to you doing things to them, the better it is for their head. It's less ICP that's going to go up, essentially. So as soon as you intubate them, you start the next day. There shouldn't be a gap between the paralytic that you gave to intubate and your sedation thereafter, right? So propofol is the sedation of choice, because it's quick on, quick off, and therefore you can reassess at some point down the line as well. And then drains, crannies, and seems to be a big part of our lecture today. But there are some studies that if you have persistent elevated ICPs, perhaps it's because you have an intra-abdominal issue. Granted, that's not in the trauma bay. That's usually the next day or the day after. So no XLAPs in the ER, please. Right? So now let's go back to some of the osmotic fluid. Let's talk about some of those. So when we talk about osmotic fluid, we talk about mannitol or hypertonic saline. So the one that we have most readily at County is mannitol. And you're going to give mannitol as a bolus, right? So what you're essentially looking to do is you're giving this big fat molecule. That molecule creates an osmotic pressure. That osmotic pressure makes you pee it out, right? So it does take a little bit of time for that whole system to happen, right? ever personally given it, you put a nice Folian, and usually about a half hour later, they start being like crazy. And that's what your goal is. Your goal is to watch them urinate all of this fluid out. And it's meant to be given as a bolus so that you can create these acute episodes of osmotic pressures, right? If you do it continuously over time, you will normalize to some degree. Then it's not as effective. It does require an intact brain-blood barrier, right? Because if there are breaks, the mannitol will go over, and then you'll have mannitol stuck on the brain side and cause more problems. So if you are concerned that there are shear injuries, that this is there's intracranial or intraparenchymal hemorrhage, then that can actually cause a bigger problem for you. But again, we don't always have that information, so you're better off treating the patient and dealing with that at a later time if that's what you need to do. And like I said, it's wholly excreted in your urine, and you want to be careful. If you have poor renal perfusion, right, then that's a problem because you can't actually urinate it out. If you have a patient who happens to have sepsis while they're at the top of the bridge when this happens, then that can also cause a problem because there's overall tissue dysfunction, which can make it harder for you to diurese. Plus, if they have sepsis, then they're already sort of leaky, and that's a whole other set of IV fluid issues. And we can talk about sepsis till the cows come home. I'm happy to have that discussion with you. Right? And you're limited by your serum osmolality. So if you're already on the dry side, right, if you just ran a marathon and you're already on the dry side, then perhaps mannitol may not work as well because you're already so constricted to some degree, so that you're not going to be able to give more. Right? And there is some risk down the line of acute tubular necrosis, but this is usually associated with many boluses. So if you go past the third, fourth bolus, then there are some of these problems.
Dr.
Yes.
Good question. So for the concern about the compromise to the blood-brain barrier, so basically epidural and subdural hematomas are okay to use mannitol, but intraparenchymal hemorrhage, you would avoid it.
With caution, right? And sometimes you don't have that information
right.
when you're looking to push this stuff.
But if you have the CT scan,
if you have the ability to know that, then yes, it would be something to potentially avoid. Absolutely. Versus hypertonic, you're just creating different gradients essentially, right? So you're giving a lot of sodium, so there's more sodium on one side of the blood-brain barrier and less sodium on the inside, right? So that by having that gradient differentiation, fluid will move back and forth. So there are limitations to this as well, right? So if the sodium is already elevated, then you're not going to have much room to go much higher. Once you go past 155, if you get up to 160, then that causes a whole set of other problems for the patient. So again, you want to limit yourself to 155 or so. And then also with your osmolality, if you're already on the high side, those are also things that will limit how much you can give. You need a central line if you're going to go above 7%. This is a pharmacy will fight you if you order 3% that you need a central line, and I don't see an order for central line, but you don't actually need it. If you're going to give a bolus, you have a patient who's in extremis, you can give 3% through a peripheral line. In fact, we do it very frequently in the ICU for a whole set of other reasons, but we give 3% as drips all the time in regular peripheral lines. Once you go above 3%, then that increased amount of saline causes damage to the actual vessels. So that's why you need a central line in order to do it, because it does become so osmotic that it can actually cause damage to the vessels itself. Same thing, when you get too high, it causes seizures, but then again, if it's also low, that causes seizures. So seizures are always things to consider when you're giving someone saline, hypertonic saline. Renal failure, again, you have to pee this out eventually, so you have to have intact kidneys to do some of this stuff. And then again, your sodium is a limitation factor. On the upside, so this is sort of piggybacking off of what Guy was talking about, there's a huge immune response that is associated with trauma, right? Not just to the traumatic injury, but all over. And so especially in the brain, when there is trauma to the brain, there's also an immunogenic response there. And there's thought that the sodium, the hypertonic sodium, actually enhances some of that mediation. So it decreases some of the inflammatory response, it decreases some of the immune response at the local brain cell layer. And also it decreases your secondary injury from neurochemical changes, right? So all that neurotransmitter that we were talking about earlier, it helps to sort of quell some of those responses. And there's some more literature starting to come out about that, but it isn't that great yet, but it is starting to come out, which is kind of nice as well. There's lots of evidence that looks at one versus the other. We'll look at really super quickly because you know that we're running late. Here's a meta-analysis looking through them, looking at mannitol versus sodium. A lot of them cross through zero, so they're not perfect studies, but there is a slight shift towards hypertonic saline working a little bit better. Another study, another meta-analysis, showed that you had a higher treatment failure rate with mannitol compared to hypertonic. So if you gave mannitol, it didn't really work, and now you're doing other things essentially. And then here's another one. So this one looks at time of ICP decrease, right? How long of a reaction do you actually get out of this? So using mannitol got you about 3.5 hours of effect versus hypertonic saline got you 45 minutes more, right? Which is sort of important when you have a patient because you don't want to have to keep rebolusing them, especially knowing that every time you bolus them, it will increase your sodium and your osmolality, limiting the times that you can use it. So getting that extra 45 minutes of response is actually kind of a nice thing. And here's another one. So this is, I like this one because it actually tells you from the time that you give it, when do you see your response? So with hypertonic saline, you actually see your response faster versus it actually decreases a little bit in the mannitol. Because you're bringing all this water into the system, it actually will cause a transient hyponatremia before it goes back up again. And that will also affect your ICPs. I'm going to rush through the next couple just because I know that we're running late. Here's how you bolus. This is how you actually dose this. So if you're giving mannitol, it's actually a weight-based dose. The fastest thing to do is ask for 25 grams, right? Because that sort of falls in between a lot of different patient weights. So the easy thing to do is you give 25 grams and then you can rebolus it as needed. For 3%, there's no actually good recommendation. So a lot of them will just say you give it until you get to a sodium of 155, but that doesn't help me as a clinician standing at the bedside. So the way I was trained is you gave it in 100 milliliter aliquots up to 300 at the bedside. So for some reason at county, when you call to ask for 3%, they actually send up 5%, which requires you to do a lot of long math to figure out how much of 100 would equal 3% would be the same as 5%. But it really doesn't matter. You can still give the same 100 mLs so you get the achieved treatment essentially. If you have a central line and you can get 23.4%, that is the most concentrated version of it. That is a 30 cc bag that goes over 30 minutes. So these sounds like boluses, but these aren't quick pushes. These are actually over a little bit of time so that you don't cause like crazy other reactions. We do have it. It's in the pharmacy though, so it does take some time for it to come up, unfortunately. These are all things that we just talked about, so I won't belabor the points that we can continue on. And the end basically is the best drug you can use is the one that you have at your hand, right? So if you can get the mannitol faster, give the mannitol. I've been trying to get 3% into the Pyxis in Trauma 1, but that's still hard to find.